At this point, I'd like to introduce our keynote speaker. Dr. Bob Dimand joined CCS as Chief Medical Officer in 2010, coming from his previous position as Professor and Chair of the Department of Pediatrics at UCSF Fresno and Chief of Pediatrics at Valley Children's Hospital. He is fellowship trained in pediatric critical care medicine and pediatric gastroenterology. Dr. Dimand was in the inaugural class of the Healthcare Leadership Fellowship of USC's School of Business and Sierra Foundation. He has previously served on the Medi-Cal Liver Transplant Committee, chair of the CCS Pediatric Intensive Care Unit Technical Advisory Committee, and is currently a member of the Emergency Medical Services for Children Technical Advisory Committee. He was also a past president of the Children's Specialty Care Coalition and served on the board of directors. Please join me in giving Dr. Bob Dimand a very warm Bakersfield welcome.
Good morning. I'm going to make a quick announcement. We have translation equipment for Spanish speakers in the back corner, if anybody wants to go check some out. Buenos días. Quería hacer un anuncio que tenemos equipaje o equipment, disculpa, para traducción en español. Si lo necesitan, está acá y nomás le preguntan a los trabajadores de CCS si lo necesitan. Disculpa.
Great, thank you so much. Really a pleasure to be here, especially that introduction that probably would only make my mother proud, but I really appreciate the warm welcome. This is my second time here. I really love coming down here. One thing I can say, I really love how the families get involved and the passion the families have shown, and then also particularly the leadership that CCS Kern County has shown at the state level over really now several years. I'm going to walk you through what CCS is, where we're going, what our challenges are. I'm going to say up front, we don't have all the answers to the future, but we're working hard on a lot of them. And I'll be happy to share some of, I think, the great services our program does and where we're going to go with this. Being family-centered is our big focus. Now, if I can drive this. Okay. We've got two screens. Where are most of the people? I'll bounce back and forth with the pointer. Unfortunately, it'll make everybody dizzy. Sometimes it'll be over here and then sometimes over here. So who are we? This is funny. Most people don't realize this. Managed care is not new. CCS is the oldest managed care program in the United States. We started in 1927. We currently cover, it's up to about 180,000 children in the state of California. One of our problems is that we cover conditions rather than the whole child. That's, I think, everyone has identified as one of our upcoming challenges for the future and an important part of redesign. Fragmenting the kids doesn't work well. We used to be a $1.8 billion program. I think we're now up to about $2.6 billion program. We're the largest children's really health program in the entire country, and we think possibly in the world also. We do two things. Everyone thinks of us as an insurance company, but we're also overseeing the care of kids, making sure they get in the right places for the right services. So we have different levels of hospitals, neonatal ICUs, pediatric intensive care units, special care centers, and I'll show you a map in a few minutes just how extensive our network is. And then finally, one of my last slides goes over some of our quality efforts of taking the entire network and using it to ensure quality. Are we too loud? Nope, is this okay? All right. We panel the qualified providers, so physicians have to go through certain things to get into our program, just like the hospitals do. I believe strongly in this, making sure that we are sending people to high quality providers, and we do a lot of things to work with people to both improve that quality and to even maintain it at times. And then finally, we have both independent and dependent counties, depending upon how large they are. And again, I really thank CCS here locally for being a leader of really demonstrating a lot of innovative ideas. So what are we doing? This is old slides, 2014-15. I've got to come up with a newer one. My main goal is still quality and access. This state is a very heterogeneous state. We have big urban areas, we have big rural areas. I'm very concerned about access in the rural areas. One of the activities I've spearheaded over the last 4 years that we have now just finished is that the interpretation of medical eligibility is the same in every single county. So that if a family moves from one county to another county, what the interpretation of our rules are doesn't change. Getting 40 counties of physicians to agree on something makes herding cats look like an easy exercise, but we were able to do that. And so I'm very happy now that if you move, nothing's going to change. The biggest thing for me is we're really focusing on being family-centered, making sure this is about the patient. It tends to get me into a little trouble periodically, something I'm not unfamiliar with. I want this to be about the patients and about the families. I don't want it to be about the industry. A lot of folks in Sacramento focus more on the industry. I focus on the patients and the family, probably because I was a bedside physician for 25 years, and it's the families that I took care of, not the industry. So I'm going to stick to that as long as I can. This is all about quality and access. We're going through CCS redesign now. There's a lot of fear and trepidation about what's happening with our redesign process. Families get worried that things are going to change for them. Let me say that the basis for this is what's called the CCS managed care carve-out. That legislation that enables CCS to be carved out of most managed care ends at the first of the year. But what most people forget is this is the 5th time that it's ended. The previous 4 times it also ended and always got extended. A lot of activity in Sacramento, what alternative there is. I've not heard one that particularly sounds viable. I'm not real worried about this sunsetting. As our egos go, the last time was 5 years ago. I was the president of the Children's Specialty Care Coalition at the time. I testified 9 times to the state legislature. On my last 3 times, when I saw people sleeping through my presentation, I got the feeling that what I had to say didn't make a whole lot of difference. It didn't. But what did matter were the families. The night before the vote, 2 parents took their kids in the West Capitol steps in wheelchairs, took the kids out of their wheelchairs and just put them on the concrete. I wasn't real happy to see that, but they did that. The TV cameras were rolling. The next morning, the CCS extension passed almost unanimously. The power of the families should not be underestimated. Your guys' voices are huge. We recently had a Family Voices Lobby Day up in Sacramento, and I participated in some of it. I can't go to the actual senators, but I know in talking to people and doing all that, they don't care what we have to say. They really don't care about the leadership. They greatly care about what the families say. So your guys' advocacy really matters. If you have an opinion that you want something done with the sunset carve-out, make sure you talk to your state legislators. They won't listen to me, which is fine, but they will listen to you guys. And so I never underestimate the importance your voice carries. Go on to next. What has changed? The federal government, who funds half of what we do, has always looked at us with a funny eye, and it's our fault. We've always given the wrong message. CCS forever has presented itself as an insurance company, and we're not. We are in part an insurance company, but in part we're what I call a public health agency. We oversee the care, we oversee the providers, the facilities, and things like that. But in continuing to maintain all of that, what we do need to do is transition from the condition to the whole child, from the carved out models we talked about to carved in. I'll show you in a few minutes why that really doesn't matter. But again, describing us as not just an insurance provider, but really organizing and overseeing the care here. We've been doing it, we just haven't claimed credit for it. And now that we've changed our message, I think people are understanding much better what it is that we do. And then, like I said, we need to get away from the fragmented care. And for me, being family-centered is easy. That's where it's always been and always should be. So what are our redesign goals as we look at what to do? Patient and family-centered approach, you're going to hear me say that a lot, but I also feel like I can never say that too much. The families are the ultimate care coordinators. We help, we assist, but any mom or dad that has a child that sees 5 different subspecialists and lots of problems, they know who their main care coordinator is, and it's not anybody on this podium, it's the families. We want an organized delivery system. We want this to be less fragmented. People shouldn't have to go crazy figuring out what form to fill out, who do they work with, how does it go. We are going to maintain our quality improvement programs. That's something I am very firm about, and I'll show you 2 examples of what we've done at the end of this talk that really underscore some of that. I would love to streamline care delivery. I've heard enough from parents that they've had to make 4 trips to the same healthcare facility last month because each subspecialty visit was on a different day, things like that. That doesn't work for the families. It actually doesn't work for the system either, because it's better to have one set of appointments and do all that. We're actually looking at some innovative models of how to make that better. And this seems so obvious. We have to learn from our mistakes. When people talk to us about what doesn't work, we need to pay attention and listen to that. And I'm actually happy to say the folks in Sacramento are starting to do that. And cost effective. Interestingly, we're not under a tremendous amount of pressure to lower our costs, so I'm very happy about that. Our budget has gone up a bunch. I keep getting the terms to me of cost neutral. I can live with that. That means I don't have to reduce things, I just have to sort of keep them where they are. Sorry about this slide. It's a little busy and confusing, but for anybody with concerns about managed care, this is the most important slide of the talk. I'll walk you through it. So this is from the 2011 state law, Health and Welfare Institution Code section. Any managed care contractor serving children, so if your kids go off into Medi-Cal managed care flavor A, B, C, E, strawberry, vanilla, whatever it is, that managed care program must maintain and follow the CCS standards, has to use the paneled providers and CCS clinics and hospitals and everything, so they can't take you out of your CCS environment. They have to follow the CCS treatment plans, have to use the specified services, and the last sentence is among the most important. This is not to allow any reduction in benefits or eligibility under the CCS program. So we already have in state law that managed care has to follow the CCS facilities, programs, and plans. My somewhat simpleton version of this is I don't care who signs the check at the end of the day, as long as the right patient is seeing the right set of providers and getting the right care. If you need, for example here, if you needed complex heart surgery, you go up to Valley Children's, who signs the check to them doesn't concern me. That you go to a CCS approved hospital with CCS approved doctors and getting your CCS services, that is what counts. And so we already have this in place, this law in place. I spend a lot of time educating people about this because I think they don't really realize that managed care, I'll use the term, has to play fair. And so really managed care should not be the enemy, they should be the facilitator. So that's part of why the whole redesign process, to me, I'm not that concerned about. I'm happy to say very clearly, no reduction in benefit or eligibility levels under CCS, and they have to use the CCS programs. So that, I hope, is reassuring to folks. Whoops. So let's go back through a little history of our program. Just this makes me feel not quite as old. CCS started in 1927, was established as a program for crippling deformities. Thus, we were called Crippled Children's Services for a long time. Not a very popular name, but that was the name that our program had. Really started with the polio epidemic. In 1935, the Social Security Act, Title V, Part 2, expanded its services for locating crippled children for both medical and surgical and corrective services, suffering conditions that could lead to crippling. In 1978, we became a little more politically palatable and changed it to California Children's Services instead of Crippled Children's Services. People didn't like enrolling in a program that labeled you as crippled, and it really made no sense. So I think we've gotten better at that. I like to stay out of politics, but if you have any question about the need for vaccines, please look at this photograph. This is before the polio vaccine came out, and this is what happens when you're not immunized for polio. You end up with lots of children and adults on iron lungs, and this is Rancho Los Amigos down in Los Angeles, where they had a room full of children and adults who got polio before the vaccine and lived in this. I cannot imagine anyone wanting to make their child live their life like this. And so I think the vaccine issue is largely an educational issue. I grew up with taking the sugar cubes. I was the first round and first era of vaccines. Unfortunately, in my times as a critical care physician, I've seen a lot of bad kids who didn't get vaccinated. Whooping cough in infants has a pretty high fatality rate. And so I think people need to understand the issues related to this. Okay. Next came, there we go. 1940s, rheumatic fever was added, cerebral palsy, as we started to be able to treat and identify some of these conditions. I like the pictures better. This is, in 1955, the first baby getting what's called congenital heart disease surgery, being hooked up to heart-lung bypass, something we now think is commonplace and very easy. It's one of the things that started after I was born, not before. So it's really amazing to me that we've been doing these type of heart surgery operations on patients. It's great, and it's actually what this transition conference is about in part. We now have so many children that have had successful congenital heart surgery that they now go on to the adult cardiologists who have no idea what we have done. They're used to seeing standard hearts with 4 chambers that adults get what's called coronary artery disease. When an adult cardiologist sees a child that only has half or 3/4 of a heart, and we've moved blood vessels around and have them on all sorts of complicated medicines, they look at us like we're crazy and want to send them back to us. So the big thing is, as we work on transition planning, what to do with kids when they turn 21, that's a very important thing, both in training the cardiologists, how we work with things, but also empowering you guys to be advocates for yourselves of how to participate in transition planning. I can't thank Tony and the rest of the team here enough for tackling this. This is, I think, the best proactive attempt at transition that I have ever seen, and I really applaud everybody and like their efforts, and I'm bringing this back to Sacramento. Okay, PKU, whoops. All right, here you can see, it may be a little tough to see in the photograph, poor little baby getting the needle stuck in the heel to go on that little blotter paper. We started doing metabolic diseases a long time ago because we learned that with PKU, it's called phenylketonuria. If you identify it in the newborn period, put them on a special diet, you will prevent them from getting mental retardation. And so we have a whole, now it's way more than one, but a whole list of things we test for as a newborn to identify these treatable metabolic conditions so that kids can live on, have happy, normal lives. And this is cystic fibrosis, added in 1961 because that was all treatable, and now we've got a lot of kids. Used to be the life expectancy with cystic fibrosis was 13 years. It's way past that now, and again, transition becomes so important. This should hopefully be about neonatology next. Yep, hyaline membrane disease. J.F. Kennedy lost a child from being premature. After that, prematurity was added to our things, and so now we have lots of neonatal intensive care units, and that has just taken off. Gone from a baby this big, being of questionable survival, we now have children down to this size. 700 grams, 1.75 pounds is now considered a large premature baby. So medical eligibility, it's now in regulations, it's there. In 2000, physically handicapping is the focus, wide range of conditions. We keep adding more and adding more. Now I want to get into how you get off of CCS. This is the challenge that we all have here, which is to me what this conference is about and what's so important. What do we do when the kids turn 21? We have CCS, someone asked me to describe CCS in 2 words, and I was able to do that. It's called value added. We add so much more to the standard care of infants and children with chronic conditions. But what happens when they turn 21? The value added part goes away. It's by state law. I can't change that age. The lawmakers have to do it. But the bigger part is we need to get the kids and the families empowered of how to work with this transition, what to do. We are putting a lot of pressure on our adult providers to step it up. We've got a large population now of kids turning 21 going into the adult world, and it's not ready for them yet, and we need to help them get ready. So again, it would sound like a broken record. Can't thank you guys enough for really taking some leadership steps into looking at this. CCS is also a financial eligibility program. You have to be at some percentage of poverty to do it, but the other part that people don't realize, you can qualify for CCS no matter how much money you make if you spend 20% of your income on your medical care. So there are 2 ways to get in. One is the standard Medi-Cal way. The other way is by spending that much. And as much as healthcare costs now, that is not unusual to hit the 20% marker. Our medical therapy program has no financial qualifications. Anybody can get into that. So you can get closed for turning 21, losing financial eligibility. If you don't live in California anymore, obviously you lose that. And then loss of medical eligibility if the condition is resolved. No point in being in CCS if you don't need it. We're struggling with this one of how to do it because if a baby gets a certain type of heart operation, for several of those, you're operated on, it's fixed, you have a normal heart, your chambers are all normal, you don't need to stay in CCS forever. We don't know at what age is best to get you out, but we don't need to be seeing kids 18 years after their surgery when they have no medical needs other than normal stuff. So we're sort of working on how to approach that one. I wish this was a joke. We now have what's called the Affordable Care Act. Someone took all of the pages and printed them out of the Affordable Care Act, and they piled them up. No, I have not read the whole Affordable Care Act. I actually don't think anybody has. It's very complicated. Its goals are much of what we talked about. It's quality and affordable health care for everybody, using quality programs, improving quality and efficiency of care, looking at all these different things. Someone asked me how the Affordable Care Act impacted CCS, and my answer was, it didn't. We're already way ahead of that. We already covered everybody with CCS. It's interesting. I made a prediction that the number of children with cancer, with heart disease, with some other major things before and after the Affordable Care Act would not change. And in fact, that's exactly what happened. Everybody with cancer was already getting cared for in California. Or I'll say all the children with cancer were already getting cared for in California. We had no more referrals come in. What it has done is gotten more healthy kids into the system, kids with minor, like a little bit of mild asthma or a cough or that kind of thing. But the serious stuff we already had. And so I'm very proud to say that we didn't pick up any more patients, which meant we weren't missing any. Covered California, just to put up here, is one of our vehicles for doing that. Again, I think it's been a great boon for getting people into a primary care system that weren't in it before, but we've not seen any more referrals. The main value of Covered California is like everything else, consumer-focused, partnering together with different programs and making that work. So how do we fit into the big federal pyramid? Like I said, we define eligibility, neonatal care, making sure the right centers are done, and working with county CCS. This is a lot of teamwork, but I think it's been great as far as getting the kids the care they need and that type of stuff. So like I said, we have been working hard and switching from being an insurance company to making sure that the regionalization of care is here. I take much more serious than being an insurance company, making sure that your CCS-approved hospitals down here are providing the proper care, state-of-the-art, That not to say, well, we're in a rural county, we don't have to follow the CCS rules. No, that's not true. We want all the local hospitals to be just at the same level as the bigger hospitals for CCS care. A premature baby here should get no different care than a premature baby does in LA or San Diego or Sacramento. And I think we're very far along the ways of doing exactly that. So we have different hospital designations. I won't bore you with all that. Different levels of intensive care units, NICUs, community centers. These are our regional hospitals, and we have community hospitals and general hospitals. This gives you an example of our challenges in California. We, when I did this slide, had 338 facilities approved by CCS. No shortage of density in the LA area. Even the Bay Area is still kind of more smeared around. But you've got no tertiary in a couple of our community hospitals up in the North State here. This is the size of Arizona, and we have almost nothing up there. If you look at the Inland Empire here, the Central Valley is also fairly underserved. So we're really working hard to take this massive geographic diversity, but always make sure our minimum standards apply to everybody. And you know, we'll be coming to visit the hospitals here soon. I know Kern Medical Center is going to get a visit by us shortly, and I think we'll be working hard on continuing what we've done, which is to be collaborative to help people improve the care. We're not here to be punitive or penalizing, but to make sure everybody's getting the state-of-the-art care that they need to get. Same here, we have 120, it's now I think 126 NICUs, neonatal intensive care units. Same thing, all across the state. Not hugely dense there, much more dense in LA, a little bit in San Diego. Even Orange County is a little spread out. I'm sorry, that's Orange, there's San Diego. Again, the valley there's some, but not as dense as we would like to see. And up here is just very little. So we're, again, trying to just bring this all together and make sure that the kids get the care they need everywhere. So we've added more than 20 CCS centers in the last 18 months. Our goal is to expand access, have more places out there for families to bring their kids to so they can get the care they need. But we're not letting people dilute the high clinical standards. I want to be able to say, if you go to a CCS hospital, you're going to get high-level care no matter where it is. And that's been really important for us. So we're going to keep working on that. Desired outcomes are more of what you've heard before. They want cost effectiveness. Care coordination is hugely important. Transition planning. Again, I just can't thank you guys enough for being proactive on this. We need to look at ways to do that. So the transition planning here that's getting started at Kern County, the TRACK program, system and questionnaire, really is wonderful. I plagiarized this from Tony's stuff. You'll see this later today. But creating a venue for people to get into transition, assess the readiness, perform interventions, and collaborate with other entities to develop individualized transition plans. This is so hugely important. I know parents are still parents when their kid turns 22, and they want to make sure their children are going on to get great health care and going where they need to go. Just two things I'm going to give you as examples of our quality programs, and then I'll stop and be happy to answer any questions. Dr. Schulman and myself, but really Joe Schulman, our neonatologist up at CCS in Sacramento, along with Jeff Gould at Stanford and others, just published this last month in the journal called Pediatrics. This is going to transform neonatal quality all across the country. First effort from CCS in a long time like this. We're obviously very proud of this, but it looked at neonatal intensive care antibiotic use. We felt that there are too many antibiotics used in neonatal intensive care for the wrong reasons. And because of that powerful neonatal network I showed you, they were able to look at 52,000 infants in 127 neonatal units across the country. No other study, no place else in the world can take this large of a network and study the patients. And we didn't just sample some of them. This is every single baby in a neonatal intensive care unit in the state of California. What we showed was that antibiotic use varied 40-fold among the different hospitals.
One hospital had 97% of their patients on antibiotics. Other hospitals only had 2.4% of their patients on antibiotics. Most important part about this is that many of the hospitals reported infection rates of 0 despite all of these antibiotics. But right here, at all levels of care, antibiotic use was independent of proven infection. So we've now shown that there's way too many antibiotics used in California. It's independent of infection. This needs to change, and now we're starting a national collaborative that Joe is leading to look at how to tackle this. We're not trying to criticize anybody here. We're trying to say we have a great opportunity to improve the care that our children receive. And this is hit the national news real big last month. Huge pressure for national collaborative. Like I said, it's in the journal called Pediatrics. It's the official journal of the American Academy of Peds, and they've really embraced it. There's an editorial accompanying this saying, this is huge. We all need to jump on the bandwagon to make this better. I think when you think about it, if you take a little baby this big and put them on a lot of antibiotics for no good reason, you've sterilized their whole GI tract. That is not a good thing. If they need it to treat an infection, no one argues with that. But if you don't, then there's a problem. Last thing I'm going to cover is we started what's called a pediatric palliative care program. I mentioned this a little bit last year. This is a program where it's really vertically integrated top to bottom care of people entering palliative care. This is not a dying program for the dying. It's not an end-of-life program. As it turns out, of the 72 patients that entered this program, at the end of our 18-month study, 70 were still alive. What you need to get into this is just a predicted 1-month hospitalization. But this is the first program we really got into where we looked at intense care coordination and really a 24/7 phone line, all of these intense services that are family-centered. This is our satisfaction survey of 9.8, 9.8s, 9.6s. Even this drop down is still 9.1 and 9.2. These are satisfaction scores our program has not seen before. Our families are happy, but not this happy. So the palliative care was a raving success as far as engaging the families, getting them going, and really being customer-oriented in our care. And lastly, it also accomplished what the bureaucrats wanted. This was the cost before the patients enrolled in our palliative care program, and these were their costs afterwards. This is the best example of what I call bending the cost curve, which is a large economic term that people use when talking about health care. So this, we accomplished both goals. We had patients do very well, families very happy, and we were able to make it more cost effective. So I'm very pleased that, again, this is another quality program that we're looking at of how to do things better. So in this, I'm going to say thank you and really happy to answer questions. And I'm privileged to have a program that serves so many families and so many people. But again, I just plead with you, speak your voices to your state government. Let people know what your thoughts are and make sure you're advocating for yourself, because nobody can tell the stories like the families can. Thank you. Happy to answer questions. When you're the early morning speaker, there's usually no questions. That's why this is better in the morning than the afternoon. Questions from anybody? Yes. I think they have a microphone for you.
Oh, hi. Thank you, Dr. Dimand, for coming and educating us as advocates and being an advocate, especially in the California state system. I appreciate that very much. I'm a parent of a severely disabled child who's benefited from the palliative care program.
Oh, great.
Probably one of the statistics you displayed. My question is, you know, my daughter's 19. Obviously, I'm here at a transition conference for that reason. Are you aware of implementing a task force focused on helping the healthcare system in general? And are you aware of any government organizations that are actually working toward, for example, a palliative care program for adults, young adults that, in my case, my daughter will be dependent her whole life as an adult as well. So her condition doesn't change just because she turns 21. What are your thoughts on that?
It's one of the few areas I actually do have some progress being made on transition. There was a bill passed in the Senate last year authorizing adult palliative care. And so we are actually helping the adult folks come up with how to provide this for adults. Like I said, I'm more interested in the first slide that shows the family satisfaction. They were more interested in the second slide that shows that it saves money. The reason I feel optimistic about that is the governor's included those cost savings in his budget. So now we're told we have to deliver, which I think is great. So I do think there's light at the end of that tunnel for your family, probably more for palliative care than there is for some of the other services. It's not up yet. If she's 19, I think it should be in place by the time you get there. So on that one, thank you. I think we do have better news than some of the other ones. Thanks. Oh, I'm getting off easy. All right. Sir. They'll bring you a microphone. Please speak up. I have problems with hearing, so it will help.
Hi, I'm Juan Gonzalez from the Kern County Mental Health team. So I guess mostly had a question as far as, I know with a lot of these kind of physical issues that kind of happen, I know it adds a lot of stress to families. Kind of, since I'm from mental health, I'm kind of thinking from this perspective, do you guys offer any kind of mental health services to these kind of families that are going through something like this, or are there any plans in the future to include that?
I'm sorry, do we do what?
Any mental health services for the families that
Is
are
it mental health services?
Yeah, that are kind of going through this kind of rough transition, because I know it's a lot of stress on families as far as going through these kind of issues. So
I think that's a great question. The state, I will say, we're not as far advanced in our mental health programs as we need to be. We're more dependent on a lot of the county services. I think it's finally being identified of the great mental health needs of two different types. One is among our current CCS clients, they have mental health issues. I think that's a little bit easier to tackle. What I'm more concerned about are sort of the primary mental health conditions that we are not doing a good job with. And so there's a lot of traction in the state of how to start to tackle that, all the way from autism and the autistic spectral disorders to some of more of the outpatient-based mental health issues. I think we definitely have opportunities to improve on that. I'm hoping we see that in the near future, but it's coming slowly. Not as fast as I would like. Right behind you. Whoops. Gotta grab it.
Sí, buenas tardes. Tengo una hija de 19 años y yo quisiera...
I'll never be able to understand her. Like I said, I don't hear well. I've had 2 ear surgeries.
I have a daughter who's 19 years of age.
Y quisiera saber si va a haber beneficios para más adelante y si nos puede proveer a cuál agencia podemos ir.
And I'd like to know if you know of any services that could be offered after she turns 21 and what agency we should talk to.
Porque sí le agradezco mucho, porque sí ha avanzado mucho mi hija, pero mi preocupación es porque ya tiene 19, va a pasar a los 20 y qué va a pasar en el futuro.
So yes, I'm just a little worried now that she's 19 and she's still in need of services, and we've gotten a lot of help from CCS and what we would do next.
Great questions, and that's why I think Tony and the group here is being proactive at looking at this. This is, we don't have answers for that within our state laws, but there are a lot of patients that need services when your condition doesn't go away. So I think that part we understand how best to do it. I'm glad you're here today to help empower everybody to speak up and start doing that. The number of adult providers who want to see the kids when they turn 21 is limited. And so we really need to work on engaging them, engaging their systems, and getting managed care to be part of the solution. So I don't have all the answers today, but I'm hopeful that this type of get-together will help to address some of that. It's a challenge. It's a problem.
Thank you.
And that's why, like I said, I'm so happy for this meeting. All right, no other questions. Again, I thank you very much and appreciate everybody listening and great questions and hopefully decent answers. Thanks so much.